Okay, so good evening, everyone. Very warm welcome to today's Resident Smart Learning Program. And I'm indeed privileged to welcome Dr. Anish Srivastava, faculty for today's class. You all will be knowing him. He doesn't need a formal introduction, but for the young residents, let me tell you, Dr. Anish Srivastava was a professor and head department of urology and renal transplant at SGPJ, and later on he was a director at the same institute. And after his retirement, his last one, he has joined Medanta Hospital, Lucknow, and is a director of urology and renal transplant program. A very dedicated teacher, very passionate in teaching the MCH and the urology residents. He was what we are now Indian School of Urology. Erstwhile, it was a Board of Education, and he has been the chairman of Board of Education. Just before me, I took the mantle from him only, and a very renowned teacher. And if you see his interesting teaching, the fellowship exam and the articles published from India, you will see the majority of these articles will be from his institute under his mentorship. With this, I'll invite Dr. Anish Srivastava to take on from here for his talk on female bladder outlet obstruction. Sir, over to you.
Okay, thank you, Arun, for this nice introduction, and my pleasure once again to be back here, I think, after some time, and be interacting once again with the residents. So I'll just like to know that if I want to interact, so will it be with you in between? I mean, to make it more interesting, or
yeah, sir, I'll give you a few postgraduates, sir. You have Dr. Charan and Dr. Naman. Charan and Naman, and I'll just ask a few others on the chat box. You can take turns to ask them questions. Okay?
Yeah, one not, but 2 or 3 are enough. Then rest.
Okay. Okay.
So they are from Manipal, Charan and Naman?
Yes, sir. Yes, sir. Yes, sir.
Okay, very nice. Very nice. Right. So as you all know, well, this evening we are going to cover a very important topic, and this is something which has always been a issue of controversy. Still, as we go along, you will see that, you know, some of the diagnosis and making diagnosis and investigations and the management, that is there is a lot of overlap, and there is not enough literature, in fact, in some areas. And as such, these problems are maybe, say, 3 to 5% or maybe 10% of the overall female problems. So, Naman, are you around? Or Charan, Dr. Charan?
Yes, sir, I'm here.
Naman is there, huh?
Yeah, both are there, sir. Both are there.
Okay. So, if you have, say, 40 years old female who presents to your OPD and predominantly with low obstructive symptoms. She says she has to strain during the voiding, and this has been going on for a few years. And when she strains, she gets better void. Sometimes she gets nocturia once or twice, and but otherwise frequency is okay. And there is no other history of like abdominal pain, fever. Once or twice she had UTI in the past, which was just treated with the antibiotics, right? So with this background, what all you would like to know in the history from her. Here she is there sitting in the OPD in front of you.
Firstly, the age of the
Predominantly,
patient.
yeah,
if she's a
obstructive voiding
post-
symptoms, which are very, very clear. She has to strain a lot, then there is some flow and
So firstly, if she's the age of the patient, and if she's a postmenopausal or a menstruating female.
yeah, still menstruating, not postmenopausal. 40 years old.
So the most common etiology that would come to my head would be a urethral stricture, sir.
Okay.
Meatal stenosis.
At the history, his level of history. Okay. So what is the difference between urethral stricture and meatal stenosis? Do we use this term with reference to the females? Meatal stenosis. So generally it is, we restrict using this term for the females, right? Because meatal stenosis is generally for the very young boys, or maybe for other elderly males, and sometimes they have BXO-like thing and all, or without. So we say urethral. Actually, for this, the term used is urethral stenosis, or maybe stricture. Arun, I think you will agree with. Okay, so so that is one. What next will come to your mind?
So the next, I would like to know any history of surgery for the patient.
No history of surgery. Nothing done on the urethra or as such on the urinary tract. No history.
And then, so any obstetric history for the patient?
Obstetric history is gravida 1, para 1, and she had a cesarean done, and everything was okay. The child is about 12 years and he is fine.
So just on history.
Any other
any
causes?
mass protruding,
Yeah.
for the vagina or urethral meatus that she has noticed?
Okay. Yes, very good. That is very important to look for either any kind of prolapse or cystosis or rectal. So there is no mark protruding. She doesn't. She says everything is fine there.
So then I'll ask the history of constipation from her.
So she is not constipated.
I think so. That's all I could infer out of this.
Anyone else, Dr. Charan or somebody who would like to add? He said he will like to rule out any gynec or obstetric related issues, and then urethral stricture or stenosis he is keeping as a possibility. Actually, that's how we term in a female. So any other things, any other possibilities, because this is at the level of history. So there are, lot of important things which you can think at this moment and then go on ruling out one by one.
Naman, what he's asking is what will be the category of causes? Then we will category of etiologies causing obstruction. Then you can look for causes. He's giving you multiple hints to you.
Yeah. So this is basically a differential diagnosis to urethral stricture, which you have very rightly pointed out that this may be a cause. Severe obstructive symptoms, very intermittent kind of uroflow, and there's nothing equivocal about it. Okay. So there can be some other differential diagnosis also. And one of them is a primary bladder neck obstruction. They will also present in the same way. Some call it a functional bladder neck obstruction.
Sir, you have the slides are moving, or you?
Yeah, I'll move along with, because
Okay, okay.
let me. I have a lot of slides.
Introduction. Okay.
Yes. So let us first build the subject, and at the level of history, and then I will cover everything, because I think they are not having much idea about the subject. That's how. Or anybody on the chat box writing some differential diagnosis? Arun, can you see that?
No, sir, not yet. Somebody has written calculus, and one has written Karankal.
Okay. So those are the things which we need to rule out. Karankal will be usually associated with a painful swelling. The female will tell you that, that she gets a lot of pain. It cannot come without that, and they generally are able to feel it also.
Yes, sir. Sir, you can look at the chat box. A very interesting differential diagnosis will come. I think the candidates are very smart. They have brought the functional causes, the neurological, neurogenic bladder, DST. Sir. Excellent.
So that is what I was to ask Naman and Charan, that those are the things. Okay. Let me look at the chat box. Chat. Neurogenic, yes. That's what the kind of answer which I was looking for. But yeah, that's how we teach. So neurogenic bladder. Now, in a patient who doesn't have any history whatsoever at 40 years of age, generally we would not keep neurogenic bladder as a diagnosis. Okay. We can keep functional obstruction. We can keep in the younger generation of females, some congenital anomalies, like if they have some myelomeningocele and stuff like that. In that age group, yes, neurogenic bladder can be one of the possibilities. Here, the possibility would be what we used to call earlier as a neurogenic, non-neurogenic. That would be more appropriate. And sometimes you call it as a, earlier the name given was Fowler's also. We'll come to that, Fowler syndrome. So that could be a differential diagnosis. It's a kind of pelvic floor dysfunction. Okay, so now what? Dysfunctional voiding. Dysfunctional voiding is another differential diagnosis. So this is the female comes under the category of voiding dysfunction, right? Because there are severe obstructive symptoms. And dysfunctional voiding is one of the differential diagnoses. So that is what all the postgraduates should understand. Very rightly, very aptly mentioned by Preet Mohan, that there could be a dysfunctional voiding. Hinman's is again for boys, was described in 1950 by Hinman when they were achieving the adolescence or puberty. And that time, the same kind of neurogenic, non-neurogenic bladder, the children used to be, constipated, and sometimes they would go to the extent of bilateral hydronephrosis, renal failure and all. That was Hinman. So in this female, this diagnosis, whosoever has Shahnawaz has written. Okay, so Shahnawaz, this diagnosis should never come here. Otherwise, Dr. Arun Chawla will be very annoyed. Okay, so that's a diagnosis for a very different group of post-pubertal boys, are the 22-year-old young man, like that. So we say PBNO, Abhinav has very rightly mentioned, as a differential diagnosis, urethral stricture, yes. Then PBNO. Then pelvic floor dysfunction as such becomes a part of dysfunctional voiding, because when we the term used for the differential diagnosis is now is dysfunctional voiding. Earlier, if you go through literature, a lot of terms were used. Even now, you read old articles from the neurourology, urodynamics, and our old textbooks. These terminologies will be there. But for today's thing, when the things have become more or less, I mean, well defined, categorized, then you should say PBNO is a better term, or if you say functional bladder neck obstruction, that could be acceptable. Okay, so neurological causes, DSST and all that, we will not keep here with this history, unless we give or the candidate should have asked any history of trauma or anything. So anyway, there was no history like that. So absolutely no point in keeping neurogenic bladder, DSST. Yes, urethral calculus and regarding the caruncle and calculus, you should have ruled it out by asking question in the very aptly said, but it should be asked at the time of history taking. Whether there is a pain during the voiding, whether there is some swelling around the urethra, that makes it urethral caruncle. So we have to basically come down to urethral stricture. We come down to functional bladder neck obstruction or PBNO, and we say dysfunctional voiding. Okay. So now at this level, for this female, we keep these differential diagnosis. Then we do a quick examination, and practically that is normal. I mean, there is nothing. It is non-contributory. So now we will go ahead from here. So even after the examination, our differential diagnoses are more or less same. Now, what should be the next step? Again, I think Naman has understood the way we have critically analyzed all the possible causes, and then we have narrowed it down to urethral stricture, as he said, and then dysfunctional voiding and PBNO. So what should be the first thing to see, or means after the examination we come to the differential diagnosis? During the examination, what else one can do to make sure that there is no urethral stricture? Because for other diagnosis we'll have to do detailed investigations and exclude. So first thing which you would like to do is, Naman?
Sir, I would like to do an ultrasonography as an extension of my examination with PVR.
So, right, PVR is 300 ml on ultrasound, and there is mild bilateral hydronephrosis on both the sides, and PVR is 300 ml.
Sir, in such a patient, uroflowmetry
yes,
ideally
should be done. Okay, and then if you quickly want to rule out urethral stricture, now urethral stricture is again a debatable entity in a female. What should be the caliber of urethra to say that there is a great possibility of this female having a urethral stricture? Anyone, even on chat box, you can suggest, because now we are going to rule it out, one by one, differential diagnosis. What do you think? Okay, let me further clarify it. Whether it should be a 14 French catheter going in easily, or a 12 French, means below what cutoff level? Because for stricture, obviously, we would like to have some cutoff. Okay. I know it has been debatable if you go through the literature, but still we have to, move further with a definite kind of cutoff or understanding. Anybody has mentioned anything on the chat box? Yes, things have come. Very nice. Okay, so that is what I was saying. Now you see, everything is there on the chat box. Okay. 16 French, 14 French, less than 12, less than 22. Okay, less than 16, less than or equal to 14, 18 French, 12. So basically, most of the residents are inclined towards 12 and 14. So this is one of the ways to rule it out, because if you see the very old literature, even they used to say 16 French, 20 French and all, because at, that time would be kept as a urethral stricture. And I'll tell you something very interesting. The practitioners, because these patients, they go from pillar to post, they would dilate. Okay, even if it is 16 French, 18 French, and they would dilate and say female will have a bit of relief, for a couple of weeks or so, and then again it will go back, and then she will go to somebody else, they will also dilate. So there was a very marginalized thing or very equivocal thing between urethral stricture for a female and the poorly understood entities at that point in time, which were EVNO and dysfunctional voiding, which we now know as, in details. Okay. So now we keep generally, if it is less than 12, there are no questions asked. It is urethral stricture, and we have to do what next investigation. Suppose it is 14, or I say, let us say it is 14 French, just going with lot of difficulty. Okay. Anything about that, we are hesitant to call it urethral stricture. So that is one thing which I don't. Do you agree with this, or you have some?
Absolutely.
Okay. So now there is an 14 French is going with resistance. So is there another next investigation for doing either ruling it out or ruling it in for urethral stricture?
Micturating cystohystogram, sir.
Micturating cystohystogram, yes. That I will show you the pictures later on, which suggest the.
Sir, you have
along
slides
yeah.
moving?
Yes. I'll have them moving. Just let me build a lot of interest to these boys. It will come. Everything will come. Okay. Now I think we have our platform ready, and now I will keep moving further, and let me close this chat box. Okay. Move from here. So we were talking about, after we have ruled out urethral stricture, then we have dysfunctional voiding. We kept it as a differential diagnosis. Fowler's is again a part of dysfunctional voiding. So anybody would like to say something about Fowler's syndrome? Because now our differential diagnosis, urethral stricture, we have ruled out, because this female, I could calibrate very nicely with 18 French catheter. So urethral stricture is ruled out. And then we are left with primary bladder neck obstruction, dysfunctional voiding. Earlier, if you see the literature, there was another term like Fowler's syndrome. Anyone has heard about it or would like to throw a light here? Naman? heard about it, or Dr. Charan?
Yes, it's painless retention of urine with usually large volume capacity in young women.
Yeah, in in younger women. So she comes in this more or less the other end of young. She's still young, and so
In the of means neurological disease, I want to add, sir, in that.
no, there
In
is no
the
neurological disease. Neurogenic bladder already ruled out.
yes, sir. No,
Examination and history, that is over. So now our differential diagnoses are, as I said, urethral stricture, that also ruled out. Okay. So
sir.
now we have these three differential diagnoses, out of which Fowler's is actually now a part of dysfunctional voiding. I'll tell you why. So basically dysfunctional voiding and bladder neck obstruction. So what were you asking? What was your question? Yeah, somebody was mentioning something. Okay. So we now come to the next entity, which is PBNO or functional voiding. And this is how the females present, right? So we have already discussed that they would present as the obstructive symptoms. There can be, you know, back pressure changes. There can be, if you do the serum creatinine in those, some of these ladies, it could be 2 or 3 or whatever. And you will have a poor uroflowmetry with normal calibration. And then how to prove this diagnosis? So we need to do a basically video urodynamics, and at many places video urodynamics is not done. So we do a I mean, because they do not have that sophisticated kind of facility. So they do the MCU, and then along with that, the pressure flow study, that is your CMG, and if possible EMG also. Again, I would mention a word of caution about EMG, that most of the places, unless it is a very thorough orchestrated setup with a very highly trained technician, EMGs are usually, you know, not very representative, because there would be some artifact, and every day a new person kind of trying to do EMG doesn't work also. Okay, so Naman, in your place, how do you do the EMG? Just a little bifurcation.
We usually put the electrodes near the inner thigh.
The surface, is it a surface
Near,
or a needle electrode?
yeah, surface electrode.
Surface
Two surface electrodes near the medium majora, sir.
Okay. So are you happy with the results of EMG in your place, or there are a lot of artifacts, disturbances, which is usual story?
Some artifacts are there, sir, not very accurate.
Yeah, and it is because the thing is that, you know, somebody who is very well trained, who has been doing it on a regular basis, we have to see the noise, we have to see the pattern. I'll show you some little later. So those are the constraints, I would say, or the limitations of EMG. So now in this case, if the MCU shows that the bladder neck is not opening, or it is just a bit of an opening, not opening properly, along with poor flow and a high pressure voiding, that gives you a diagnosis of PBNO. And you have already ruled out urethral stricture. Now, this is a very interesting slide. I wanted this background. Now, Dr. Chawla will understand why I wanted the background, all the differential diagnosis, to be very clear to you all before going further. This is one of the very important radiological image of the studies, where you can differentiate kind of to a great extent. Okay, so now you see the first slide where there is a because here the bladder neck is not opening properly. You can see some dye leaking, but most of the times in the, if you do a video urodynamics, you will find that this area, it is not opening, and at the same time the pressures have gone very high and there is a very poor flow. Okay, so this is one. And second is the obstruction at urethral sphincter. Now, what is this? This again, I will say that this picture and the next picture, they are both the part of Naman. They are both the part of voiding dysfunction. Yeah. Voiding dysfunction. Okay. So stricture ruled out. PBNO may have some kind of picture like this. And then in voiding dysfunction, there are two things. One is a kind of a rhabdosphincter around the urethra, and then the pelvic floor, which we were talking about, mainly levator ani. Okay, so if the picture is like this, the dilatation limited to this, they say that it could be the obstruction at the rhabdosphincter level, a little higher up. And then if it is like this, then it becomes an obstruction at the pelvic floor muscle, or we say that these are the skeletal muscles, whereas this is a rhabdosphincter. So, but every time one may not have such nice, pictures. But in dysfunctional voiding, you will find this kind of picture. Then in D, this is what we were talking about. There will be some dilatation of the urethra and the narrow thing here. And then calibration 12 to 14 and below is the cutoff. If you are not able to calibrate, you get a picture like this. We confirm the diagnosis of urethral stricture. And then these are rare pictures, I think. These are rare pictures where there is an obstruction at two levels. This particular author has described, but these are very extremely rare. So, and this is of course that pelvic floor thing, high grade pelvic organ prolapse and obstruction, which we were talking about earlier. And Naman, you very aptly said that we need to look for this. So basically, for the postgraduates, the important thing is to differentiate between a dysfunctional voiding and a PBNO and a urethral stricture, where the video urodynamics comes very handy. Okay. Now, coming back to, I think, maybe a point in adding about the Fowler's, going back to this slide, why Fowler's is a very rare diagnosis. For Fowler's, you need to do 2 EMGs simultaneously, whether it is the rhabdosphincter which is causing problem or it is the levator ani. So that kind of differentiation, if you do highly academic study, then this is because of the non-relaxing perineal floor. Fowler described this syndrome. And then, okay, let me ask a very basic question. What relaxes? Does the sphincter relax first during voiding, or the bladder contracts first? Aman? What happens?
So bladder contracts first.
Huh? Bladder contracts first.
Naman, how the voiding cycle starts? After storage, the act of voiding comprises of 3 steps. Please mention in order.
Okay. So it is basically by 0.04 milliseconds. It is the sphincter which relaxes first. And that gives signals to the bladder, and then the bladder contracts. It is only a difference of, if you see a lot of physiological studies and other things, you will find that this is what happens. Okay. So in non-relaxing perineal floor, which was a differential or a term used, again, they all come under the basket or the category, wide category of dysfunctional voiding. Okay. And if you have a picture like this, then but then you have to do an EMG, because only radiological pictures, they can give you a suggestion. But if you are talking about diagnosing Fowler, then she in England, she diagnosed it with 2 electrode study, and then she has shown that this sphincter was fine, relaxing in time, the rhabdo, but the functional or the external sphincter or the levator ani, which we say main part of the pelvic floor, this was not relaxing. So unless you have that kind of picture and a very high grade EMG differentiating with the 2 different needles amongst these 2 areas, putting needles in rhabdo versus levator ani, because whenever we put our electrodes, they are basically representing levator ani. Okay, that's why the diagnosis of Fowler is as I said, is very difficult to diagnose. And now, because this never relaxed, therefore, these patients were not having enough signals for their bladder to contract. Same thing happens in Hinman also. They do not get a signal for the bladder to contract, and therefore their bladders gradually dilate. Sometimes they go to the state of atony also. Initially, they would be always high pressure, and then they may sometimes become kind of acontractile. So those are, various things, and that is why they present with these children, or these ladies with dysfunctional voiding sometimes might present with renal failure. This is the theory is same for Hinman. In Hinman, it is much more common, I would say, as compared to this dysfunctional voiding in the females. Okay, so now again, this is a voiding CUG basically, with lot of back pressure changes and poor opening of the urethra here, suggesting a functional bladder neck obstruction. Okay, same kind of thing here. See, and then coming to the urodynamics, you will see that in EMG, as we said, there is some relaxation here, but again artifacts here. And if you see the PDET, it is very high. For a female, what should be the criteria for the diagnosing obstruction? Anybody will tell? Here, obviously, it is very high, as you can see this curve on the PDET. But otherwise, even less than that, what are the criteria? These are different pictures, again showing very high voiding pressures and a very poor flow with a poorly opening bladder neck, suggesting functional or primary bladder neck obstruction as a differential diagnosis. So in this female, if you get a picture like this, like these, one of these, you would be putting them under the category of female bladder, primary bladder neck obstruction. Now, these are the definitions. They have been changing ever since. And if during voiding, during voiding, more, according to one author, more than 25 PDET Qmax, here it is more than 21, 25, and Qmax of less than 11 or 12. This combination with fluoroscopic evidence should be enough for us to diagnose PBNO, and along with that, if you can show a nicely relaxing EMG, so your job is done. This is that same thing on the nomogram for diagnosing the primary bladder neck obstruction. And then I think for the management, if they are in retention for quite some time, then we need to, and as I said, sometimes there a long-term obstruction can cause a flail bladder, or the bladder could become, kind of hypocontractile, but if you do CIC, they do CIC for some time, the bladder tone recovers. The role of alpha blockers is basically again controversial, and Arun will agree that Paul Abrams, when he came for our urodynamic classes in Manipal and at other platforms, whenever we have interacted, he says in females there are no alpha receptors. But on the other, so he says alpha blockers probably should not be used as a part of management. But on the counterpart, the authors, many authors from US and from Europe, they would say, no, alpha blockers have some role. So you can all see some studies. Issue is if the female has already got, like in this female, the index female, which we talked about, had some back pressure changes, and her creatinine is also borderline. So in such cases, I think there's no point trying alpha blockers. We should go for surgery. And if you see, this is what is the role of alpha blockers, as you know, in other thing also. And we also published way back in 1999 from SGPGI, the functional bladder neck obstruction. And this study in 1999 was probably the second or third, or maybe in this area, because there were not many studies in the literature. The more studies have come later on. And we also showed the use of pediatric resectoscope for the bladder neck incision. The reason is, if you try to do a bladder neck incision using a Collins knife, the resectoscope, because female urethra is very short, so the moment you need to cut from bladder neck to coming to the mid urethra, and the moment you come to the mid urethra, water spills out and your vision goes, bad. So we suggested that a pediatric with the resectoscope at a Collins knife, there are two advantages. Generally, we give the incision at 12 o'clock, because those who have given incision at the 6 o'clock, occasional cases of rectal injuries or fistulas are very occasionally reported. So it is always safe to cut at the 12, and you can do other incisions at other places also, like here with these things are very individual. And here you see, this is the Collins knife, which is cutting the bladder neck. Here you can see on the 12 o'clock. Sometimes the neck is so thick that it happened in the same female which I am describing. It was a very thick thing. So what we do is we cut always, in females, because of the fear of continence. It has to be tailored, done with a bit of fear that if you cut, more, then they might develop some kind of incontinence, even if it is at 12 o'clock. So first time I did a conservative kind of a bladder neck incision, but then I did not get good results. And then I resected, like what you are seeing here. And then she had very good results. So occasional bladder neck resection also helps, depending on the kind of bladder neck which you are dealing with in a particular female. See, these are the transurethral views. And here you see the two incisions given. So, but generally I personally avoid giving incisions at 6 o'clock or 5 and 7. Arun, what is your practice?
Sir, again, it depends upon. I'll try to give only one incision and see how it is opening up, either 5 and 7. If needed, then I'll give, yeah. So limited, and this incision is not like what you do for a neurogenic bladder. It's a very limited incision, just inside the bladder can come very, very limited incision. Yeah.
Yes. So that is very important, and it is always better to call her again and give another incision or deepen it down, because there is a very thin line. We are walking on a very thin rope between incontinence and the good outcome. So this is another paper, same, more or less same thing, which we, and in short about the urethral stricture. So if you definitely found, suppose not in this female, if you found urethral stricture, Naman, what is the treatment for that? Definite urethral stricture is there. These are the, like in males, these are the etiological factors, same. And this is the definition. As I said, there has been always, this definition in a female has been loaded with, overlaps and controversy. But now most of the people agree that if it is below, cutoff is below 14 or 12, with MCU finding, as I described earlier, it is a case of urethral stricture. This is what in past, there are various ways the authors used to define urethral stricture. Symptomatic, anatomical narrowing, calibration, visual inspection, all these terms. We have discussed this, we have discussed all this. Here there is a picture showing the same, and dilatation doesn't work. Do you think any role of myotoplasty, just a myotoplasty doing? Arun, what is your belief on this myotoplasty? Just doing a myotoplasty.
Yes, sir. Again, it's very difficult to find a very isolated structure just at the tip of external meatus. But however, if it is done again, you can take a call on a soft calibration or a metaplasty, like a blindish metaplasty, again with a little limited risk of a little vaginal widening.
Perfect. So therefore, generally, what most of us do is an augmentation, urethroplasty. And so because as Arun very aptly said, you will not find a ring, in most of the cases, a definite ring, like in a child, you have a, definite meatal stenosis at the tip. It's not like that in a female. And therefore, this is still practiced, if you will see, but then the results are very, I would say dismal. And because now we have understood this thing, so probably we should not be doing dilatations lifelong for these females, giving them only temporary relief. And sometimes even, they can progress into bad bladders and, back pressure changes and all. So this is again, we discussed already, and this is what we do. So after making an incision on the dorsal side, I'll show some pictures there, and then a good graft is taken from either the vagina, or there are some who say the best, as we all know, also the best graft, free graft, is a oral mucosa graft. So between dorsal and ventral there are issues, but most of us do the dorsal. I think Arun will agree with that, but it depends. And grafts, as I was saying, vaginal grafts are most preferred, because nearby place you can just take a graft and put it over the incised urethra. You have to go for the placing the graft for maybe for a centimeter or whatever, till where you could find the normal urethra. This is a comparison of outcomes you can see here, and dilatation is not much to be advocated. And generally it is like this author, the Chapel, he's the president of the European urology section, also very well known name in functional urology, urodynamics. And so this is what is his recommendation, is to dorsal approach and a free graft. I'm not sure whether you can appreciate the pictures here, but I think to some extent, yes. And then here the graft is placed after giving the incision. This is how it would look like at the end of the urethroplasty. Okay, so now this was basically the presentation with the urethral stricture and PBM. And I have also shown you basically how we diagnose the the dysfunctional voiding, what are the MCU pictures and all. So I have some more material all hidden, but I thought today the postgraduates will be presenting and discussing. So there was a bit of miscommunication. Anyway, so now we can uh, go for the question answer session. Arun, do you think,
sir.
or you want to add certain more things and then we can clarify
No, sir.
here?
At their level, I think how you classify the BO into different categories is important. You have to bring it anatomical and functional. In functional, you have to bring it neurogenic and non-neurogenic causes. Anatomical, sir has already spoken to you metal, but again, this urethral stricture, again, diverticulum, prolapse, and other associated causes which can cause obstruction from outside has to be in the reckoning. Neurogenic already is this. Other functional causes, what he described very nicely, the 5 pictures, and that primary bladder neck obstruction, you had a Fowler, you have a pelvic floor, all this, if you see the MCU, and if you have a good urodynamics, the diagnosis is clinching. The management also he has very nicely, but the main idea is how you put into a different category. That is important, and based on history and examination, you start from there onward till picking up the investigation. The sequencing of investigation is very important. And again, what he has told is the video with the primary bladder neck obstruction is very difficult to diagnose and is based on video urodynamics. But in absence of video urodynamics, he has explained how to probably crack the diagnosis. For resident level, sir, this was enough, I think. Then further as is basically techniques and all that, we can keep on showing videos and diagrams that will not be of much relevance. How do you say, sir?
Yeah, I think for them, I was just going through, yeah, that should be okay. I was just going through the chat box. Most of the residents have written the answer, sphincter relaxes first. So
last question you can take, sir. Last question.
I give them full marks. Yeah. Now the last question is, see, that's what I was trying to say, that it is very difficult to identify that the problem lies with rhabdosphincter. Unless that's why, you know, the diagnosis of Fowler's also came into kind of a shadow or controversy, because the sphincter complex, what we study is the levator ani. Okay. And in voiding dysfunction, now, yeah, I think very rightly, this was the category which we have not discussed much. So let us discuss about the not voiding. Let us discuss about dysfunctional voiding. So Abhijit, you should correct that. Voiding dysfunction is a category of the entire thing, as I said, you know, the whole obstructive symptoms. It is the dysfunctional voiding, which is a differential diagnosis. This also you should learn and be very clear in your mind today that, yes, very nice. Dysfunctional voiding. Voiding dysfunction is an umbrella term. Okay, right. Now we'll discuss all these questions here, and I think very nicely asked and very apt. So first question was the rhabdosphincter. Now, unless you are able to identify that there is an issue with the rhabdosphincter, as was seen in the differential studies from the Fowlers, nobody else is very difficult for them to, you know, differentiate. Therefore, there is no role of fulguration of rhabdosphincter, because it is difficult to identify, and even if you identify in mid urethra, you do some fulguration, But how are you sure that that is responsible for dysfunctional voiding? Okay, Arun, do you agree with that? So there is no
Yes,
role of fulguration of rhabdosphincter. Okay,
absolutely, absolutely.
proximal limit of
Rhabdo
BNI.
center has to be rhabdo center. I
Ah,
think you will. Okay, sir. Continue, sir. I'll come later, sir. Continue. Sir.
okay. No, no, we can finish it off here only. Yeah. So
No,
then
I
I.
think that's what he has written fulguration. First I wanted to find how he got this term fulguration of
Idea.
rhabdo. Yeah, that is.
No, no. I think that is how our residents are, think, and his thinking is very apt. That when I have been describing rhabdo, external sphincter, levator and eye, pelvic floor. So then why not, kind of concentrate or focus on this. But Kanishka, no, not Kanishka, Rahul.
All right.
Yeah, Rahul, it is very difficult to, as I said, identify. And unless you identify, have you, okay, we cannot have two ways. But anyway, so that's not there. Then proximal limit of BNI in females, like Viru it should not be proximal, we should say it is distal limit, because it is coming from inside the bladder to outside. Yes, very right. In what happened? Okay. So the distal limit is mid urethra. That's why and because female urethra is very short, it may be difficult initially, especially for a beginner, to assume how far we should go. It's a very, very relevant question. And so it is described as mid urethra. So first when we go in, so we kind of gather with the experience that this urethra is about 3 centimeters or so, or 4 centimeters. Then we start from the bladder neck and just come down to mid urethra. Okay, so that is the limit. Then the role of Botox in in dysfunctional voiding. Well, there is some role, but that is more, when you have patients who have in fact, because we are looking at the kind of focusing on the sphincteric level. Therefore, in dysfunctional voiding, the suggested things are the skeletal muscle relaxant, like a baclofen kind of thing, which do help. Some add alpha blocker as well as baclofen also, where you think that you are dealing with dysfunctional voiding based on the investigations, as we said. Arun, what is your choice of combination of treatment when you see this dysfunctional voiding? From the, of course, some lifestyle, then constipation and all, taking care of all those things. Have you?
Yeah. Okay, sir. Now the issue here is how we diagnose dysfunctional voiding. Usually, you have to look at the not only the voiding part. Usually, they will have something related to bowel also, because this is related to pelvic floor.
Yes.
So it is a what you can say, a composite management. Right, it starts from the counseling. It starts from the counseling. You have to take a good history. It goes from the counseling onward to pelvic muscle floor relaxation exercises up to that. Then we keep on moving forward by seeing the responses of this. You have to take care of constipation. You have to take care of the avoiding function. You have to take care of the psychological component. You have to take care of the medical. So it's all you have to look at the patient in totality. So it's not an isolated. Only the voiding part you have to see.
Yeah, that's right. So, as I said, I have been giving them baclofen with some relief, and Botox Yeah, there are a couple of studies where they have, in the same area, they have kind of gone there and injected Botox with the uh, variable results. Neuromodulation, yes, neuromodulation is also one of the modalities, but I think it works more in overactive bladder. What do you say, Arun? Not in to that extent in.
And now, what has happened is the neuromodulation. Initially, we started from overactive bladder, but now we are seeing this
Oh, there are some.
neuromodulation
Yes, yes.
being used in pelvic floor disorder, in bowel, bladder, and multiple indications for that. So for that matter, but the actual is not. When we talk of neuromodulation, it has to be sacral neuromodulation, which has different arms of action, not the what you can say the tibial nerve stimulation, which is primarily meant for OAP.
Yeah. So somebody said, if UDS is not available, uroflowmetry suggestive of obstruction, I think you should refer him to Arun.
What is it?
Good center, like Manipal or Rusha Surti is asking, when the facility of UDS is not available, when the uroflowmetry is suggestive of obstructive pattern, if you can rule out a urethral stricture, Rusha, then you should not, venture anything further without a good MCU and a urodynamics. What do you say, Arun? We
Yes,
should
absolutely.
making
Rishabh, the
decision
important
on
thing
the bladder
is,
neck and all.
yeah.
Yeah.
So you need to look at MCU. Again, MCU
Yeah.
should not be like a casual attempt in filling the bladder and just getting a voiding fluid. It's very important. You have to have in your mind what you are looking at. So you do a good storage picture. You do have a good voiding picture, and if you have what you can say a fluoroscopic machine, you can have what you can say the best this way of the fluoroscopy. You can intermittently you can expose the patient and see how the voiding is going on. That is very important. Taking a still picture, a voiding case and seeing the related urethra or the bladder is one thing. Seeing the MCU, the voiding face on the fluoroscopy is another thing. So this is important. But having UDS, not having a UDS out to this is tricky. Now, why we are doing UDS is basically the obstruction has to have a low flow and high pressure. This is basically the thing which we want from UDS in when we are doing avoiding, and the activity at the pelvic floor, which we get from EMG. So these three components are important. The when you have a primary bladder neck, then you have the video. So the UDS has a different role combined with video dynamics another role. But if you say without the UDS, probably I'll figure it if I'm very sure with the proper history. This lady has undergone multiple dilatation, has already have a different history that she every time she gets dilatation, she gets leave for 6 to 8 months and then comes back again. And then she gets dilatation, she gets leave for 6 8 months. Probably yes. Again, it's all based on your experience, how you plan your management.
Yeah. So it is better because I have seen, some patients of dysfunctional voiding. They have been subjected to multiple dilatations for few years. Their typical description is that when the doctor dilated, I had for maybe 1 or 2 weeks, I had some relief. Then it has come back to the square one, right? So when you are kind of trying to give an incision on the bladder neck, you must make sure that you are not dealing with dysfunctional voiding, and that would be possible with a combination of ideally a video urodynamics, but otherwise a good MCU and a pressure flow. I think that's what we take it as a consensus. Now, urethral hypermobility and all, I think these are tangential questions. Harish, and because that would be more a part of the stress, SUI and all that. And probably a more relevant question, baclofen, I have already addressed that. Yes, there is some evidence-based literature, and in clinical practice also I have found it useful. And then first line investigation, 60-year female with difficulty voiding. Well, again, they would at this age again, as we talked about, we rule out the urethral stenosis, and by calibration, and then MCU must be done. Yes, it should be done, because either you will find a stricture during calibration, even then we confirm with MCU, and if you don't find, again we need to do MCU with voiding difficulty, documented and supplemented with the findings of a poor flow at least, and maybe high PVR if it is there. But sometimes high pressure bladder, they can empty their bladder. Females can empty actually with even 10 pressure, 10 or 12. So when they have high pressures, they can sometimes empty. They're not necessary to have a high PVR. The PVR starts rising when they have, kind of decompensation. And in the same breath, I would say that the underactive detrusor is not a standard term for the females. Madhur has asked that question, and that is for the obstructed males. Arun, do you agree with that? That underactive detrusor kind of thing? Is it a standard terminology with females also, or?
Actually, is seen and diagnosed more commonly in males, but it has some mention in females also.
Yeah. So Madhur, that is what the answer is. And okay, any other questions? So I think we have discussed everything, whatever is there in the chat box. So Arun,
yeah. So I think the chat box and no more question I can see. I think fresh question comes, we'll take it immediately. Yeah. Fine, sir. Okay, and so I think on behalf of Indian School of Urology and Urology Society of India, I like to place on record my heartfelt thanks to Dr. Anish Srivastava for accepting our invite for smart learning program for the residents. This topic is a little complex, but I think you have made it quite simple. What actually is meant or what actually is needed for the resident, you have explained in a very lucid way, and I think they won't commit any mistake now. They are very clear now. The way we had a question in the chat box, I think probably it was a well accepted and well received presentation and with this, I thank you very much, and I thank all the residents who joined in for the program. And I thank Navneet and Kiran for the logistics support. With this, we'll sign off, sir. Thank you and good night, sir.
Okay, good night. Thank
Bye,
you. Very nice. Best wishes to all the residents for their future exam.
Happy. Wishing you all. See you next year.
Yes.